Welcome everybody to the second session of the EBMT Family Donor Day today. My name is Andrea Linke. I'm a member from the EBMT Patient Advocacy Committee, and with the other patient advocates, as well as Isabel, who is the representative of the EBMT Nurses Group from the country of the annual meeting this year, and that's Spain. I welcome you very much to this program. I'm from Germany and I had a stem cell transplantation 18 years ago. At that time, my daughters were 3 and 5 years old. I will chair this session together with Isabel Salcedo, PhD, a research nurse from Madrid, who is a member of the EBMT Nurses Group Research Committee.
Good morning. Welcome to this second session of the Patient, Family and Donor Day. For me, it's an honor to be able to chair this session with Andrea, and I hope you all enjoy it very much.
The session is about post-transplant care regarding sexuality and fertility. These are very important topics for all cancer patients, even if after the immediate diagnosis, they don't seem to be. However, sexuality and fertility will become important again after the transplantation, that's for sure. Now we will listen to 3 short talks, each about 10 minutes long. At first, we were happy to welcome Roseanne Bursma, a patient from the Netherlands who went through her transplantation in 2017. She is sharing her experience about sexuality and infertility with us. Thank you, Rosan. After that, Andrés Moreno, MD and PhD from Valencia Hospital in Spain, will talk about pediatric and young adults' fertility after hematopoietic stem cell transplantation. And last but not least, we have Caroline Lovett, who is working as a psychosexual therapist at the Royal Marsden Hospital in London, UK. She will be talking about psychosexual therapy after stem cell transplantation. She had problems joining, so maybe we won't be showing her presentation. That depends if she can join the session. If you have any questions, please write them into the chat box during the talks. Isabel and myself will address them to the speakers after their talks, and as we have a 15-minute time for question and answers. And now let's hear the patient's voice first. Roseanne, the stage is yours.
Good morning, everybody. My name is Rosan. I'm 37 years old, and today I was invited here to talk a bit about my own experiences with sexuality and fertility after a stem cell transplantation. I'd like to add intimacy to this because I do think these three are very strongly connected. Talking about these subjects is sometimes a bit uncomfortable, also for me, but I do think it's very important to open up about this, and here I am, and I will do it via my own story and my own experiences. When I discovered I had blood cancer, I had acute lymphoblastic leukemia. A group of doctors came to my room to talk me through my medical process and my medical situation and the treatment that was about to start. And while the doctors were talking, I could only think, do whatever you want. You need to fix me. I need to get better very quickly. My mother was sitting next to me and she said, I have a question. And I thought, oh, there we go. And she said, what about her fertility? Can you freeze her eggs? And I was furious. My mother, who wasn't a grandmother by that time, but wanted to be, was more worried about whether having a grandchild than having a healthy daughter. And of course, she didn't mean it like that. But for me, it felt at that moment like this. I had only one priority, and I was getting better quickly. And in that time, I was in a relationship with a very nice guy, but we knew each other 3 months before I got sick. And it's not a really good basis for going into this roller coaster that's called cancer. So during treatment, sexual activity, or actually sexual feelings, were below 0, non-existing. And during recovery, it didn't get any better. I couldn't enjoy sex, it hurt. And I thought, let's wait a bit. I was still recovering, maybe 2-3 months later, miracles can happen. But 2 weeks after I finished my treatment, I got a relapse. And then my doctor told me, okay, you need a stem cell transplantation just to survive this. And once you have this transplantation, you will not have any babies of your own anymore, because radiation is killing almost everything that you have. And I thought, okay, no worries, let's first get better. In May 2017, I had a stem cell transplantation, and recovery took me a while. My boyfriend wasn't around that much. Actually, there were days, and quite a few, that I felt more sick and anxious about my relationship going down the drain than I was worrying about getting better and being very sick. And I can tell you, I was really sick in the process after the stem cell transplantation. We broke up, unfortunately, in 2018, but luckily we're still very good friends now, and I cherish that. And slowly during 2018, I got back on my feet again. I wanted to be part of society again, but I wasn't feeling very comfortable in my skin. I gained and lost a lot of weight during the whole process. Short hair. I felt like a little insecure fat boy. And also the question whether I was ever able to have and enjoy sex again was spinning around my head. Do guys fall in love with girls like me? With not being able to make babies? Do you fail when you cannot become a mother yourself? And so I thought it was time to take some action, because I learned through the whole process that as a patient you really have your own responsibility and you need to seek help yourself. So first I went to a psychologist and at the cancer center in Amsterdam, and he helped me amazingly. And I went to the gynecologist. I had problems sleeping and heavily dreaming, and still no sexual feelings whatsoever. And I also was curious about what was going down there, because I had some vaginal dryness, and I also was curious if I had still some eggs left. So my doctor told me I was in an early stage of menopause and my egg reserve was extremely low. And she gave me some medication for my hormones and also some moisturizer for my vagina. And she told me that if I wanted to have a child in the nearby future, I had two options: or having a lot of sex to give those few eggs that I was still having a little bit of a chance, or egg donation in the Netherlands. And I thought, okay, the first option, having a lot of sex without a partner and a dry vagina, maybe not a good idea to put this into practice. And the whole egg donation was just too big of a step for me by then. And in the meanwhile, my hormones started to get a bit better, also with some adjustments in lifestyle, because you can do a lot with food and stress reduction and exercises and whatsoever, although it's still trial and error, but I'm doing better. But I felt on the sideline of life, and I needed to reinvent it a bit. That's how it felt for me. And I didn't know how and where to and what to do. So my psychologist asked me, what do you want? What do you know that you want? And I thought, yeah, I want to go to Japan one day in my life. And I don't know what happened, but I went home, I called my doctor, asked if I could travel to Japan. She was okay with that. I booked a ticket. And 6 months later, because I gave myself some extra time for recovery, I was walking in Japan by myself for 3 weeks. And actually the time that I spent in Japan was, for me, it felt like a victory. More than finishing treatment. I could enjoy life again, I could climb mountains, even was my own pace. I could eat everything I wanted and it was amazing. And I even could look in the mirror and liked myself and was even proud what I had accomplished. So when I got back home from Japan, I had so much energy, and I had also an urge to live and also to start dating again. And 3 months later, I met this amazing guy, And we started dating, and I really liked him, and I thought, okay, he's 35, he probably wants kids, and I need to tell him something. So on date 3 or 4, I know it's early, but yeah, I thought, and I said, hey, I need to tell you something. I told you about being sick. Well, this is a problem. I probably cannot have children of my own. And he said, okay, but let's not talk about this right now because it's way too early. We're just dating. And I thought, okay. And so, okay, let's see. We'll see. And a guy should know that if a woman says, we'll see, she actually means we need to discuss this right now. So I waited a bit. I did my best. But on date 6 or 7, I said, hey, remember you didn't want to talk about it? I want to. Because if you want children, and only on a natural way, which I cannot probably give you, better walk away right now. And it was a bit of a risk, but the outcome is very positive because we're still very happy and still together. The last year we had a lot of conversations about becoming parents. We did some research, I did some medical checkups, and we recently chose to start the process of egg donation. We'll see what happens. It's a process that we just started, so nothing is set in concrete, and it's a process we do together, and I really enjoy that. And I can still be very sad sometimes that I cannot have any children of my own, like a little Roseanne that I was with cute blonde bangs and reading books all day long. Maybe a bit childish as well, but I also think it's a bit painful that you have to pay a lot of money for having a child before it's even born. And it's not an easy road, but I had more challenges in life. And it would be amazing to become a mother one day. And if that doesn't work, I don't know how I will respond to this, but I do know I'm also very happy with the life I live right now, with my family, with my boyfriends, and also just about the fact that I'm very healthy. I hope with my story I gave you a little bit of an insight how I dealt and experienced sexuality and fertility. Actually, it's infertility. During my treatment, and I told you things that I didn't even share with my family yet. To finish this presentation, I would love to give you some advice for patients, but maybe for everybody else as well. If you experience pain or uncertainty about sexuality, intimacy, infertility, never wait until your doctor or care professional starts to come up with it. All professionals really want the best for you, but they cannot know how you feel or what is going through your mind. You need to follow your own guts. You let the shame and the uncomfortableness, let it behind you, even though it's difficult, and I know, and I experienced this myself. But once you open up about it, you will feel much better and maybe even be relieved, and it helps you to recover even more. So thank you for listening to my story, and if you have any questions, I'd be happy to answer them later. Thanks.
Thank you very much for sharing this experience with all of us. Now it's the turn of Mara and her presentation. Please go ahead, Mara.
Wait a minute. Good morning. My name is Andrés. I am a pediatric oncologist, and I am the coordinator for the Fertility Preservation Pediatric Program in Valencia in the Hospital La Fe. Thank you very much to the organization for the opportunity to participate in this interesting meeting. I have nothing to disclose. Cancer in children is rare, The frequency, histology, and evolution are very different from the adult population. During the last decades, survival rates for cancer in childhood have increased dramatically. More than 70% of these patients are curable with surgery, chemo, and radiotherapy, and they will become long-term survivors. The cause of cure may involve fertility, which may have a deep impact on the quality of life of the survivors. The side effects of oncological treatment may be acute after therapy or start several years later. The nature and extent of this damage depends on the severity of illness, the dose and the nature of the delivered agent, the treatment schedule, and gender and age of patient at the time of the treatment. As we know, cancer therapy may have adverse effects on the reproductive system. These consequences mainly result from a direct effect from surgery or radiotherapy on the neuroendocrine axis and direct or indirect damage to the gonads due to chemotherapy and radiotherapy. To estimate the risk of gonadal dysfunction after treatment can be especially challenging due to the varied nature of the gonadal injury and the few late effects studies published in young patients with cancer. In the case of females, to understand the extent of damage, we remember that the human ovary contains a fixed pool of primordial follicles, maximal at 5 months of pregnancy, which begins to decline with age, culminating in menopause at an average of 50-51 years old. Chemotherapy and radiotherapy may deplete this ovarian reserve and cause a premature menopause and infertility. It is difficult to establish the individual contribution of each drug, but alkylating agents as cyclophosphamide, busulfan, and tiotepa, normally used in bone marrow transplant, have been associated with a premature ovarian failure. In male, spermatogenesis is strongly vulnerable to the damage effects of these alkylating agents, and oligospermia and azoospermia often results. The prepubertal ovary or testis is not protected from the effects of gonadal toxic chemotherapy. Radiotherapy to the pelvic area in both males and females is likely to cause gonadal damage. Fertility and puberty can be also affected after total body radiation as conditioning therapy in selected hematological diseases. Also, radiotherapy, in a dose and age-dependent manner, has been implicated in causing uterine damage with decreased volume and elasticity. Follow-up is important, and endocrine pediatric teams must be involved. To estimate the risk of infertility after cancer treatment for a child and young adults can be especially challenging. Practical recent gonadotoxic risk classification have been proposed. As we can see, total body irradiation, busulfan, and tiotepa are related with high risk of gonadotoxicity, data absolutely comparable with adult population. In this slide, we summarize the main options for fertility preservation for cancer patients. We distinguish the experimental or established character and its applicability according to pubertal development. Cryopreservation of semen from adult men has long been an established option. Cryopreservation is rapid, non-invasive, and widely available. For prepubertal boys, strategies for fertility preservation are experimental. Ovarian cryopreservation plays a leading role in pediatric fertility preservation and women who cannot delay the start of chemotherapy. And we can see for adult women, we can consider alternative options. Oocyte vitrification represents the ideal fertility preservation option in case of benign diseases, and in cancer women if they are post-pubertal and if chemotherapy could be delayed. The disadvantage is that 2-3 weeks are required to perform hormone stimulation. In this moment, it's not considered as an experimental technique. Moreover, recently is it considering this technique as an option of fertility preservation after treatment in patients who have not exhausted their ovarian reserve, but they will do it at an early age. Ovarian cryopreservation is at present the only that could be offered to prepubertal female patients. The advantage of orthotopic ovarian tissue reimplantation are the possibility of natural conception and hormone restoration. The aim of this strategy is the long-term storage of this tissue before gonadotoxic therapy and its reimplantation into the pelvic cavity once treatment is finished. The patient is disease-free and she experiences premature ovarian failure and subsequent infertility. This is the multidisciplinary process necessary for the proper implementation of the program, which includes many professionals: oncology, pediatric surgery, anesthesia, fertility and biology teams, and tissue bank of Valencian community in our case. This is the chronology for the procedure in our center. In the case of hematological malignancies, to decide the best moment for ovarian cryopreservation in leukemia patients is not easy due to clinical situation, a diagnosis, urgent need of starting treatment, and no clear indication of stem cell transplantation until evaluating response to chemotherapy. As per our protocol, we perform ovarian cryopreservation just before stem cell transplant, at the same time as central line is inserted. Nevertheless, the risk of reintroducing malignant cells into transplanted tissue is the main concern of ovarian cryopreservation. This adverse event is especially challenging in patients with hematological cancer, such as leukemia, the most frequent malignancy in childhood. Therefore, new safe alternatives are being developed to optimize ovarian reserve in these patients, as primordial folliculus in vitro maturation and oocyte cryopreservation after in vitro maturation. The development of these techniques will make it possible to avoid tissue reimplantation that is currently contraindicated in leukemia patients. Regarding our experience in fertility preservation options for adolescents and semen cryopreservation, in the last few years we tried to offer the called adolescent-friendly facilities, open, sensitive, comfortable discussion about infertility risk conducted by their oncologists or well-trained nursing staff. High quality and realistic information may reduce level of anxiety before the procedure. Sperm banking at home or at the oncology unit, different place than fertility clinics, without parents present, may increase the success rate. A psychologist should be available to help complex reproductive decisions involved with patients and their parents. A relevant issue is that it's important to perform it before any chemotherapy. Researching projects involving prepubertal boys are underway. The approach is to remove and cryopreserve gonadal tissue from suitable patients at high risk of infertility before cancer treatment. This option may preserve the survival and functional capacity of the spermatogonial stem cells. The generation of full spermatogenesis from prepubertal tissue have proved to be successful in several animals, including non-human primates. However, these approaches are very much in their infancy. So to conclude, I would like to remark, patients conditioning with total body radiation or alkylating regimens are a very high risk of premature ovarian failure. Even very young girls show high rates POTS after stem cell transplant. In our experience, ovarian cryopreservation was safely and efficiently carried out. Prior low gonadotoxic chemotherapy may be considered if ovarian failure risk is high. We consider that the timing chosen by our program is adequate. This schedule allows to perform several procedures at the time, especially central line insertion, to offer ovarian cryopreservation only to stem cell transplant, and stable complete remission and clinical stability at the time of collection. And in males, I would like to summarize. Sperm banking should be offered to all both physically and emotionally mature young males who will receive gonadotoxic treatment. Adolescent-friendly facilities may improve successful rates. Prepubertal boys who are at high risk of infertility may be carefully selected for testicular tissue cryopreservation in the specialized centers, only for researching projects. Multidisciplinary teams should be set up in the cancer centers to help resolve the practical and ethical issues surrounding fertility preservation in young cancer patients. Thank you very much for your attention.
Thank you very much, both of you. Unfortunately, Caroline has not been able to sort out her technical issues, so we won't be able to enjoy and learn from her presentation. We apologize, but this is what happens when we do sometimes live sessions, and we are sorry for that. So we're just going to start the Q&A session. I welcome you all to send us some questions for the speakers. I think the presentations have been excellent, and we should just try to make the most of having these excellent professionals and patients just to have some discussion with. We have received already some questions. The first one is for Mara. It says, thanks for an excellent presentation. And it says, at one point of the diagnosis, do you introduce to patients and parents the fertility issues? And how do they usually react to these discussions in your own experience? So Mara, please.
Hi, interesting question. We try to explain or to inform about this topic at diagnosis, not the same day of the diagnosis, but more or less 1 or 2 days after the information of the diagnosis. We, in our program, we are very selective with the offer of ovarian cryopreservation in the case of female, because now is currently is an experimental technique, and we try to offer patients who has a high risk above 50% of risk of infertility. We try to do, we inform every patient, but we try to offer these options or these techniques only for selected patients. The reaction of families are extremely good. They are very happy to listen that that the oncology team is not only worried about to cure the illness, but they are also worried about the long-term late effects, and reaction is extremely positive. Patients and families especially, but patients as well, especially when they are more than 10 years old. Normally they like to see this option, and normally we try to do this procedure at the same time of other anesthetic procedure, and this is easy. This is one of the this is important to not to convince, but to because they they want to have an easy way to do that, and to try to do in the same anesthetic procedure, it's much better, but extremely good reaction.
Thank you, Mara. I have a question. Who's paying for this? Because in Germany, it is not paid for, the health insurance. In Spain,
Yeah. Now here, I know that there are different policies between countries. Not many centers here in Spain can offer that, especially for pediatric population. I can say that maybe only 2 or 3 centers offer this option in this moment. And now it's covered by national insurance. Families and patients don't have to pay nothing in this moment. I know we are very lucky about that, because things are different in other countries. But now here in Spain, I don't know if it changes, that things can change, but at the moment they are covered by national insurance.
You were saying, I think I got you right when you were saying that at the moment this is an experimental treatment. That's what you said. Is it like in your center, or is it something that is happening worldwide, or how is this going on?
It's now it's changing. Maybe I think there are several countries that now consider ovarian cryopreservation like an established option. But in European countries, American as well, and in my case, Spain, I think still is considered an experimental option. Maybe with the positive data that we have about newborns and the consideration of a safe procedure, things can change in the next few years. But now, if you is not is considered as an experimental technique, but the only option is vitrification of ovocytes, and it's not possible for prepubertal population. But I think I am very confident that the consideration of experimental technique is going to change in the maybe in 1 to 3 years, in the next 1 to 3 years.
Thank you. I would like to come to Rosan and thank her for her beautiful testimony. We had the question from one clinician who's asking, I totally agree that it's important for patients to share what's most important for them. How can we as clinicians best ask this? Can you share any insights on how clinicians have found a good way to discuss these priorities with you?
Yes, of course. It's not easy. There's not a clear answer, actually. And I do think it has been a while ago. I was 30 when I got sick for the first time, 2014. And it's, yes, they talk about it. They ask about it. Also, my doctor herself, when they are next to your bed, when you get sick, maybe. But in the later stage, after the stem cell transplant, they ask you how you're doing, and you need to fill in sometimes lists like how are you doing work-wise, how are you doing mentally, and then you fill out 0 to 10. But that's really difficult, because what are you? Is it an 8 because based on your medical history you're doing quite good, or is it based on, if you look at all the other healthy people who make babies and have great sex, you're the 2? And I think they asked for it, but it's really easy as a patient, if you feel a bit ashamed, to just give an easy answer and to let it go. And I do think it should be maybe more of a more separate subject, where they ask more questions and and go deeper into these questions. So not if a patient says, yes, it's okay, I'm having sex, then ask, okay, could you explain a bit more? Does it hurt? Or are you okay with it? Or are you doing it because your boyfriend wants it or your girlfriend wants it? All these, yeah. There's not a very clear answer to that. But in the end, I had more problems with sleeping very heavily, sleeping bad and heavily dreaming. And then my doctor told me maybe it's good to go to a gynecologist. And the gynecologist was actually the first one who really asked me, like, okay, how is sex going? And then I told her, well, it hurts. And then she told me, I can help you. We have pills for your vagina. And if you're starting to think about having sex again, you could start with some small vibrator or whatsoever. So the gynecologist was the one who started to talk about it. But the difficult thing for a patient is that the gynecologist doesn't know a lot about all the other stuff you went through. So it's just not a very easy...
I agree. It's difficult to find the right gynecologist who knows about stem cell transplantation. Did you also have experience with sexual therapists at hospital?
No, I didn't. And because I felt okay with the advice the gynecologist gave me. And I also learned, I think that's the only privilege after being sick for more than 2 years or 3 years, that you learn that you need to ask questions and that you need to be honest about things. But in the first period of being sick, I was, yeah.
Thank you.
Thanks a lot. There is another question for Rosan. It says, thank you so much for sharing such experience with us. I am a positive believer of the help that patients can provide to each other. As you said, as healthcare professionals, we sometimes focus on different outcomes than patients. So from your words, it seems that you were always the one addressing these personal issues with your healthcare professionals. Did you not receive any psychological help or counseling when you went through the process? And then it's similar to the previous one. What do you think the role of nurses can be on this pathway?
They did ask me, I didn't have specific help for this, but they were addressing these personal issues. But as I also said before, it's very easy if you don't want to talk about it as a patient to let it go, to say something, to give them an answer that's convenient for them, and you can go on. Because there is still a taboo on this subject, and I think more even for patients like me. So they did, but sometimes you just don't feel comfortable. Also with the person who's sitting in front of you. If the nurse sitting in front of you doesn't feel comfortable to talk about it, you feel it. And then you also start being uncomfortable. When somebody's really open about it, like the gynecologist, who for her it's very normal to talk about these things. For me, it also became slightly normal. But it also depends. I had a psychologist from the cancer center that's very close to the hospital. And it was a guy, and I didn't feel comfortable talking about it with him. So it's not only if the help is there for you, if there's a person, if there was a sexual therapist at the hospital, I don't think it's immediately the solution for everyone, because it also depends very much on if you click with them, if you feel comfortable with them. And I am very lucky that I had a nurse practitioner who I felt very comfortable and trusted with, and I could tell her everything. But after the stem cell transplantation, I didn't see her that much. You come in another section of people who are supporting you from the hospital, and you need to start comfortable with them again, and that takes 2 or 3 sessions before you are there. So yeah, it was offered, but I think for a patient it's too easy to leave that behind. It's very uncomfortable to talk about it. And I experienced this also with other patients, because sometimes we talked about it. mostly after stem cell transplantation, and after that you were doing good again. Yeah.
Roseanne, thank you. We had another question to you. How do better prepare patients they may experience problems with intimacy after stem cell transplantation?
And understand if it's more part of your whole process from start, at least it becomes a bit normal to talk about it. Because if when you get sick and you arrive in the hospital, there's only one thing everybody thinks: you need to get better, and myself too, everybody. And I do think there was not a lot of space in my head at that moment for sexuality, but also intimacy. And most conversations with the psychologists were more about, okay, how am I coping with this? How do I get my place back in society? But never this intimacy and the sexuality. And I do think if you bring it in from moment one, of course the patient can say, okay, not right now, but then it's on your mind and it will stay on your mind because it is a thing. And then slowly you can feel comfortable and start talking about it.
Yes, I agree. However, it would be wonderful if there would be a sexual therapist also at every hospital one could address.
I think it's definitely helpful. And I do think if you have, if the doctors would say to me, okay, next Tuesday, a sexual therapist will come and see you to talk about it, I would like, oh no, don't do this to me. But I do think if somebody is sitting next to you in your bed or you have an appointment somewhere in one of the rooms, I do think it's good to address it. And not only sexuality, but also this intimacy part, because actually that's more the difficulty.
I have another question for Mara. It says, I have been a member of a research ethics committee for a long time. At what age can the young adults or adolescents sign the consent form by themselves without their parents? So I think that the question reads as, from the legal point of view, when are they entitled to decide for themselves about, fertility issues in Spain? And then if you have any information about other countries.
Okay, really, I am a pediatric oncologist. My patients normally are less than 15 years, and it's normally they have to assent and parents have to sign. I think at least here in Spain, for health topics, the age for having autonomy to sign is 16 years, but I think for reproductive techniques, I think you has to be older than 18. And I think in between 16 and 18, there is sometimes there is a gap, because you are still enough mature to have your own decisions. But in the reproduction topic or issues, I think you need to be older than 18. And I have to say that I don't have this problem because all my patients are minors, and I try to inform every patient, including children, and especially for older than 12, I try to that children older than 8 have to try to sign as well with their parents to give their consent. I think this is the point. 12 is a good age to consider mature. Maybe you have to individualize, because with this age you can find a lot of personalities, but you have to think about it when they are older than 12. But from the legal point of view, I think the point is between 16 and 18. 16, it's more, I think it's more or less the same that clinical trial, that there is an exception, because normally for other issues, if you are older than 16, you can decide, but for clinical trial and techniques related with fertility and reproductive techniques, you have to be older than 18.
Thank you, Mara. We have another question for Roseanne. Have you shared your experience with other patient or patient groups? How do you feel about patient peer support groups?
Yes, I did actually, but it was not organized by the hospital, but I met a lot of people, of course, in the hospital during treatment after stem cell transplantation. And sometimes we became familiar with each other, and there was one or two girls a bit around my age generation, and then sometimes we met after the hospital, or we went for a walk in the park in Amsterdam, and we talked about these things. And of course, it first started with how are you doing, and are you going back to university or whatsoever, but also we talked about our sexuality and the relationship, and if it's possible to get babies, yes or no. And I just understood she just got a baby, so that's very positive news. There was not a peer group. I can imagine it's a good thing, although it also depends a lot who is in this group, and if you have this connection with people. For me, what helps me is when people like the social worker or the nurses, when they told me, hey, how is your sexuality? And they said a lot of patients after stem cell transplantation have symptoms like a dry vagina, and sex can be painful. For me, it would help me, because I thought, okay, so I'm not the only one. I can talk about it. It's actually normal for patients like me. That helped me being open about how I felt and where I was going through.
Thank you, Roseanne. I want to wrap up now because our session has come to an end. Thank you all for your great presentations. This is a very interesting and important topic indeed. I want to wrap up, as I said, and as a transplant patient, you have to be proactive and ask for support yourself. And best you ask at your cancer center or your gynecologist, and don't accept pain during intercourse, and don't have sex anymore. That can't be the solution. Thank you all. Bye.